Welcome to The Other Side of Medicine, a trusted source for education, not medication, for 35 years. In every episode of The Other Side of Medicine, we deliver health information your doctor won't tell you about. My guests are the nation's leading health experts in science-based natural medicine, physicians, authors, researchers, and clinicians. We believe natural medicine should be first, drugs and surgery last, and so we promise to deliver you the next generation of health information built on three principles: common sense, science, and cooperation with nature. Well, good evening, everyone, and welcome to The Other Side of Medicine. I'm Dr. Krystosik, and we are glad you're spending some time with us. Today, we have a very special guest on the program. It's Dr. Zach from the Zach Performance Health Center in Westlake, Ohio, and he is an expert in active release technique. He's a chiropractic physician, an educator. He teaches anatomy courses. He's very well versed in this technique and very accomplished. He has treated many professional athletes, and without further ado, I'm going to welcome him and let him give a little bit brief history about his background. So, Dr. Zach, welcome to The Other Side of Medicine.
Thanks for having me, Dr. J. Pleasure to be here.
Yeah. Tell us a little bit about your background, if you would, please.
Sure. So I've been fortunate now that I'm in my 25th year of practice. I started out at National College of Chiropractic, now National University of Health Sciences, and graduated in December of 2001. Started my kind of career when I was a student, had some exposure to this course called Active Release Techniques, which at the time I didn't know really much about it. Went to the course and kind of fell in love with it. And it's been part of my driving passion through my career. We'll talk about that here shortly. But I've been fortunate and blessed to have been working with pro athletes, like you said, a little over 20 years now. And I also teach for active release techniques, again, for a little over 20 years. So I've been around the country educating people in this technique as well. So, and now I'm in private practice in Westlake.
Sure. So you have been fortunate enough to be able to treat professional athletes. So tell us a little bit about that.
Yeah. So early in my career, it started back in 2004. So I was only a few years into practice. And at that time, the Cleveland Browns had reached out to me due to the specialty treatments that I do. And we formed a relationship in 2004. I wasn't even in the Cleveland area at that point. I was still in Boardman, Ohio, where I'm from. And I saw a patient, formed a relationship. And then in that year, I started my practice up here in 2004. And then by the next year, I was hired on as a consultant with the Browns. So I've done 3 different regimes with them. As with our team, there's been many regime changes. So I've been in and out, but I've had experience there. I've worked with NBA players, Major League Baseball players, pretty much every professional athlete out there I've dealt with. So I've been blessed to be able to enjoy that kind of career. It's been fun.
Yeah, you also treat musicians as well.
Yeah, correct. I've also been treating a lot of musicians, classical musicians, because again, it deals with some overuse injuries, which we'll get into. So yeah.
Well, let's talk about the history and the art of active release technique.
Sure. So active release techniques is what ART stands for. It was developed by a man named Dr. Mike Leahy, who you have to remember back at the time when he came up, this was just mid 80s. He was at that time in medicine, there really wasn't much of a technique or a great effective way to treat soft tissue injuries, right? At that time, it was pretty much going to be medication, heat, cold, and rest. So Dr. Leahy himself, a little brief history there was, he was an athlete himself. He was actually played basketball at the Air Force Academy. And
now we're talking my sport and yours as well.
Yeah, for sure. He was actually a Top Gun fighter pilot for the Air Force. And through his training of engineering and aviation, he used a lot of those principles later on in life to come up with active release techniques. Dr. Leahy, I believe, started in private practice in 1984 in LA, and he started working with elite athletes. And with elite athletes, what they want is quick results. When you get quick results, word spreads fast, and he's soon built his practice. The technique, I believe, was started to be taught to his peers in 1993. So he pretty much had about 9 years of working on things himself, and he was working on a sports diplomat, and some of his colleagues would say, "Hey, can you share some of this stuff you're doing here?" So in 1993, he got together with a group of guys, led by another Dr. Tony Criscolo, who was the first guy that prompted him to do this from Jersey. And he did a 1 day full body course teaching about, at that time, what later became known as active release techniques. So that was kind of the history of how it got started. There was a need for it, and he kind of came up with it. So that's what I would say for
Okay,
that.
good. Well, that's really interesting. He seems like a really interesting character, and kind of ahead of his time, which
Yeah.
is pretty neat. Talk about cumulative injury disorders and how that connects with ART.
Yeah. So cumulative injury disorders is something where it could be from either overuse, from active injuries, or sustained hypotension from postural syndromes. Um, and when those things are happening, it creates a damage to the tissue, which leads to scarring and tightness. And we could show you a graphic to describe that. But the bottom line of it, Dr. J, would be this: like, to keep it simple, is, as I tell patients, if you imagined if you pictured a paintbrush and all the bristles that would be free, right? If we took that paintbrush and we painted something and we didn't clean it out, the bristles would become hardened, right? That's an example, very easy example of how we could picture the texture and the tension of, in that case, the paintbrush being changed. That's kind of what happens with the muscles from overuse, from trauma, and from postural syndromes. Is it changes how it feels, it changes how it moves, and it ultimately has an effect on blood flow, which is oxygen. So that's kind of how we get into that, and an easy way to think about that, but affects, in a sense, the muscles, the tendons, the bones, the blood vessels, the fascia, and the nerves. All that stuff kind of gets affected.
Yeah. So how do you go about diagnosing that kind of a problem?
Yeah, great question. So when we're diagnosing a situation like this, we're going to use palpation, primarily, meaning with our hands. We're going to feel the tissue. Before we get to that, we would first talk to the patient about how, their history of what led to them, what their symptoms are. But ultimately, to get a diagnosis, um, we have to identify the nature of the lesion, right? So we do that with our hands so that we could find the exact tissue involved. We want to be able to feel, is the tissue moving properly, or is it kind of adhered to its neighboring surrounding structures? Um, when we can do that, and we can kind of figure out, is it a tear to the tissue, is it adhesion, is it something of that sort, what exact tissues is involved, then we may be able to put a name on it, like it's a syndrome of carpal tunnel syndrome or tennis elbow, something like that, right? So it's just more specific type of diagnosis. When we have that, we're able to share that information with a different practitioner or whatnot to get effective treatment and be more specific with our treatment of it.
Okay. How does the tissue, movement of the tissue and the connection between that and the motion of the joints and all that connected, how does that all work?
Right. So basically, I think you're asking, how do we integrate it with even like traditional chiropractic, potentially with the joint? Do we know, is it the joint, is it the muscle, something like that? Is that where you're going with it?
Yeah, absolutely.
Okay. Yeah, great question. So in treatment of it, what we're looking for is to determine what is the primary cause going on here. Is it the joint maybe not moving properly? Or is it the muscle that caused it? Could be both, and likely it is both. And it's going to be by palpation. So um, if we're palpating a tissue, oftentimes, to give you a quick example, a patient may come in and feel a pain in their, let's just say their hip, and they think that the whole source of the pain is their hip. They're convinced it's the piriformis syndrome, which is a common thing people have heard of. Very easily for a practitioner is you can palpate that area and you're going to feel, is there a texture and tension difference in that hip tissue? If you can feel there's nothing, it's moving freely, there's no adherence going on there, we know clearly it's not coming from the hip, right? It may be referred pain from the disc, lumbar disc, or joint not moving properly. So to get that answer is going to be often through palpation. It's going to often be through watching them move. Very often I'll put them through a movement screen to kind of see a couple things. Are they moving in full range of motion? Do they get pain? Any kind of limitations like that. So I'll often tie in something called selective function movement assessment, which is a different screening tool to kind of screen the patient as well to kind of determine what you're asking. Is it more joint? Is it muscle?
Yeah. When you're looking at the joint, though, it's really important for our listening audience to understand that there's different ways of evaluating if the joint is functioning properly. And you and I both use a technique called motion palpation. And that is when the doctor looks at the ranges of motion of each specific joint. If we're talking about, let's say, the sacroiliac joint in the pelvis region, we're looking at if the joint is moving, properly in all ranges of motion. And that's something that's very distinct to a selective group of chiropractors that looks at, again, each joint in a specific range of motion, whether it's in flexion or extension or rotation or lateral bending. And that's something that we're talking about here as well, right?
That's correct. Yeah, that's definitely part of the assessment. When we make the determination of what is the culprit, I think that's the most important thing, is finding out the root of it. But yes, exactly. When it comes down to the spinal level, we would use motion palpation to determine which range is limited, and then of course we try to restore that through an adjustment, and if that's applicable.
Yeah. So yes, just establishing that, then when you're looking at the soft tissue, that's a whole different scenario.
Correct. So with the soft tissue, I think the trickiest thing for someone new learning this to develop is the feel through your hands. It's very easy for us that have been doing this for a while to grab a hold of somebody's tissue and be able to feel exactly what's going on. But it is an acquired art form that you develop, because it's not only, Dr. J, is the tissue moving, but there's levels of the tissue, right? As me and you have spoken about live, is there's depth to tissue, right? So it's not all about just put my hand on a thigh, for instance, and what do I feel? I may have to go through a couple different layers and understand, what am I feeling? Is it the muscle? Am I dealing more with a fascial limitation? Is there a nerve entrapment? So I think the biggest thing to this diagnosis that we're talking about really is incumbent upon your touch. And that's something that you develop through practice.
Yeah. And over the years, you have actually taken ART along with a bunch of other techniques that you have acquired along the way in your learning process. Then you've actually incorporated those into your practice, and you've actually you made a hybridization of all these different techniques into your own specific technique. And that's why you have gained such popularity, because you have specific techniques that you use that are really just used by you alone.
Well, I don't want to take credit for any of that. I mean, I've had a lot of great mentors along my path, right? And I feel like I've been fortunate. I'm somebody that's always willing to learn. And no matter where I'm at or who I'm listening to, if I could sit back and just soak in the information, that's why I think I'm always evolving, is because I'm always humbled enough to always continue to know that somebody else out there is smarter than me, typically. So through my journey, you're right, I've learned a lot of different techniques, and I kind of pull from them what I like and what ways I could use it together. But I think at the end of the day, what is important to me and how I use things is through two lenses. One, I'm always looking through the lens of function. how does this affect someone's function overall? And the second part is basically anatomy knowledge. I think one thing that sets me apart is I know anatomy really well. And then whatever technique we should use, it's just application of that technique towards the body, right? And then just
Yeah.
so
Well, let's take a look at a specific example. Let's say a person comes in with some low back pain. Okay,
sure.
how would you begin your evaluation with somebody who's got chronic low back pain, or maybe even has an acute injury?
Sure. So, as an example with somebody with low back pain, just to give you something that we probably would see typically, um, sometimes when somebody has a problem with the low back, they may come into me with here's a great example is somebody that came in to me once with their whole presentation was in their foot. And they had a numb tingling in their foot, and they were convinced they were really coming to me because they thought they were coming for plantar fasciitis, right? They had foot pain. So as I sat down and talked with the patient, and the first thing I'll do is always just sit and listen to their story, if you will, and I'll be listening for key things that's important to me. All right, I'm developing an idea in my mind of what are potential causes. So in this particular person's case, it was somebody that came in with just purely foot burning and numb tingling. Um, as I listened to their history, they had been to a podiatrist who's a foot specialist, and I listened specifically for what have you had done to you, what worked, what didn't work. As soon as I hear the case where someone's had, for instance, like a shot of cortisone in the foot and it gave zero results, we pretty much have a good idea right there. It's not coming from the foot, right? They've done some interventions to the foot. I've had a case where they actually had a surgery to the foot, and this was referred to me by a podiatrist who said, you know what, I'm having some problems here. Take a look, see, and see what you think. The person has had a foot surgery to no avail, has had injections to no avail. I sat down with them and literally, Dr. J, within 5 minutes of talking to them, had a pretty good idea. I was like, it's coming from your back, like pretty clearly. I put them through a series of tests to confirm my idea that it was back. And I did some orthopedic testing. And within minutes, you have an idea it's coming from your back, because when you know the body, when you know the patterns of where nerves supply, and it's a fancy word called dermatomal pattern, which just means an area of skin that a particular nerve supplies. So when you could talk to a patient and detail out where exactly do you feel what you're coming to me for, and then paint that back to what is the only logical thing that can cause that, right? Then you would then just keep going deeper. Orthopedic tests, neurological tests, then palpation, and then you talk to the patient about what you're getting, because you can imagine when someone's coming in with a foot complaint and you're there to tell them, no, it's actually your back, they're probably going to think you're crazy.
Uh-huh.
So it's that educational part to bring them back to where it is. But then if it is the back problem, usually it could be a disc condition. I integrate with that kind of situation. I'll often integrate a technique called flexion distraction technique, which is the use of a specialized table to decompress the disc, get some fluid pumping in the disc. We'll use some flexion distraction therapy. I'll do some active release techniques to the tissues as applicable, and then I'll often still adjust the joint too. And then the big picture, what we'll do is we need to have the patient do some specific stretching, and usually then offer them some strengthening to do, because that's really I think the big way that people can stay out of pain longer is then to strengthen. So that's kind of an example of a little case there.
Yeah. Well, it sounds like, you have developed these techniques over time. And, I always tell people that when you get somebody specialized like you, 80% of the chiropractors are going to be able to help a lot of people with their problem that they have. But then you get those difficult 20% cases.
Yeah,
And that's where I think you really come in, because those cases have these cumulative, injuries to their, fascia, their muscles, to their
exactly.
connective tissue. And that's where you can get into a more
Yeah.
exact diagnosis and treatment. Is that a good
Yeah,
assessment?
that's exactly right. I think our chiropractic peers out there are doing a great job with a lot of conditions and can help a lot of people. So you nailed it right there, that it's going to be, where does somebody need to seek me out specifically, is for more where you're having that tough case that you're just not able to clear. You're not able to get, fix it. And then you kind of send somebody to like me where I might be able to see it through a different lens, than just purely like a mechanical type of view, right? But yeah, it's exactly right and I do see a lot of those cases where it's those stubborn things that people have had some difficulty with. And then they just send them over to me to see if I can take a look at it and possibly help them get through that. Yeah, exactly
Well,
right.
I could talk from personal experience with you, Dr. Zach, because I was in a really bad car accident back in March of this year, last year. And by all practical purposes, I either should be in a wheelchair or I should be dead right now. And I had gone to actually 3 or 4 chiropractors, and I did get some temporary relief, and I did get a little bit of relief, but the problem just kept on lingering on. And I've been now going to you now for about 3 or 4 treatments, and I've seen significant improvement. I'm not 100% better
Yeah.
yet, but
Yeah.
I see that we're on the right path, and it's made a huge difference for me. And the other day when I was being treated by you, after you treated me, I was able to get off the floor and kind of just jump up like I normally do. And
Yeah.
I'm 76 years old, and I play basketball, full court basketball with college students at universities, and I play full court, I'll play for an hour and a half, and I haven't been able to play, and so I'm getting back to that ability to be able to go back on the floor, and I'm so appreciative of what you're being able to do for me. So it's kind of like, again, that example of the other chiropractors gave me some benefit, but they weren't able to get to the root cause, whereas you're getting to the underlying root cause.
Yeah. Yeah. It was interesting because as we talked about before, having the ability to have numerous techniques in your treatment bag, if you will, I think is advantageous because if all I had was a hammer, everything I see is a nail, right? So the fact that I can pull from a different bag of tricks, of different techniques, every patient may need something different. So even though, yes, I specialize in soft tissue injuries, muscles, tendons, ligaments, nerve entrapments, um, that doesn't mean that every patient that comes in to see me is going to get active release techniques, for instance, or every patient is going to get, flexion distraction treatment or whatnot. Everybody may need a little something different, and I had to do that with your case too. We had to use a variety of different things just based on what I thought you needed. So it was an interesting case. We could talk about too, if you'd like, kind of some of the things I got into with your situation, but
Yeah,
uh,
please kind of share that, because I'm not averse to having you share that, because again, my condition has been chronic, and it's been going on now since March, and I've just recently gotten some really good relief from what you've been doing. So talk about it, please.
sure. So in Dr. J's situation, when I had seen him here a few times ago, um, I looked at the situation. There was really a lack of motion, big time, through his spine, through his lumbar spine, through his thoracic spine. He wasn't moving well. Okay. And as I got to know Dr. J through some talking to him in session here, I saw that he had a passion for movement, and he was somebody that loved playing basketball and wanted to get out there and gain that back. He had had some tragic accidents that had happened, and I was going to do everything I could to try to help him get back that motion. So we started um, with his case. We did, like anybody else, a history. I then put him through a brief movement screen, which is it's the basis of what I talked about earlier, called selective function movement assessment, or SFMA. I put him through a couple of movements where I had him, for instance, bend forward to touch his toes, and I was not just looking for does it hurt, but I was also looking for does he have full range of motion, or is it limited? So we put him through a series of motions like that. I put him through just like mimicking things that would mimic how he moves, like swinging his leg like in a running stroke. I then had him stand tall and do a hip extension to look at firing patterns. So I'm looking at functional stuff too when I was evaluating him on day one. Did through all that. And what I saw in Dr. J was, like I said, movement was not good. His firing patterns were not where they should have been functionally. Instead of the glute being the primary the primary hip extender, I think his lower back, I think it was, right, Dr. J, your lower back, I think, was dominant. And I think on one side, your hamstring was.
But
So I'm just,
also right around T12 was really restricted as well. And
yeah,
that was also a very chronic problem. I knew I was cognizant of that. I was aware of that before, but you addressed it in a whole different fashion than anybody else has ever done because you worked
yeah,
on soft tissue simultaneously.
yeah. So I kind of like to first, like I said, I get a lot from the history, and then I use the quick movement screen just to get me a good idea of what I think it is. Then I go to the orthopedic testing to make sure stuff's safe. Do we have anything serious going on that we have to send out to somebody else, or is it something that I could deal with? So I checked his orthopedics, checked his neurological screening, um, and then when I kind of felt that it was something that I could deal with, I talked to him about what I thought I saw. Um, and in my mind, I told him, like I would tell any patient, yes, there's a technical diagnosis that we could tag to this, but a lot of times it's just the academic side of things. It doesn't really help Dr. J get back to moving and playing basketball. What he really cares about, what most patient cares about, is when can I get back to doing what I want to do? Will this hurt? How long is this going to take? Right? That's what the most consumers care about. They don't really care about for me to sit there and get academic and give you a bunch of fancy words that you're never going to remember, right? So as we started care with Dr. J, I started with him doing a couple things. I used the flexion distraction technique, which is a table like we talked about, just to I want to do a little bit of work on his discs. Also use that table to get some joint movement. And then I used active release techniques, of course, but based on his limited ranges of motion at that time, I had to use some other techniques as well. So I did some active release techniques to Dr. J's hip flexors, some stuff in his lumbar spine, some hip rotators, some hamstrings, just to try to overall loosen up the area the best I could. Also, in his situation, I chose to use a different technique called the arthrostem, which is a device. And I wanted to specifically put some stimulation into the joints in a specific manner that I thought would be beneficial in the stage that he was in at that point. So I used that. And then we also did some we did some motion palpation to figure out where we wanted to adjust. And I also adjusted him. I knew that in his case, it was going to be something that was going to take a little bit of time because he had been through such trauma with his the auto accident that he'd had. And I believe, was it a bike accident too, Dr. J?
Yeah, I had an auto accident, and then I did something really stupid. I was riding my bicycle to get a chiropractic adjustment one day, and I was talking on my phone, and I got to a place where there was a crossing the street, and there was a curve that kind of declined, kind of down, and I didn't see it, and I went flying through the air, and I landed. Thank God I had a helmet on, and
Yeah.
I it really had another injury on top of the car accident, which was really crazy. So
Yeah. So,
don't ride your bicycle and talk on the phone. That's for sure.
but due to the traumas that he'd had, I knew that there had been some scarring that had happened. There had been some big time limitation going on. So you're not going to see those cases turn around right overnight. It takes a minute. And so I wanted to tell him that, right? And as we went through, we're slowly but surely each session getting better movement. And the last time I had seen him, which was last week, we started to notice that his mid back, his lower back was starting to move a little bit better. Now, in the big scheme of his case, there's more work to do. And really what's going to happen is then we're going to start transitioning into some strengthening stuff with him and teach him how to kind of stabilize better to get back to doing what he wants to do. But that was just an example of how we tackled that case. But
Sure. Well, the thing about it is that you also worked on my psoas muscle,
yeah,
which is really significant, and you've done a part of the active release technique on that muscle, which is
yeah,
really a paramount in helping to correct this underlying cause of what's going on. But I wanted to also say that I'm as a chiropractic physician myself, my primary thing is chiropractic, but I
hmm,
really have fell in love with functional medicine. And ever since I graduated in 1986, I've been studying and researching with functional medicine. So that's become really my forte. But I also, of course, my background is chiropractic. I have treated thousands of patients with chiropractic techniques, motion palpation, and I've used what's called the myofascial release technique, which is a soft tissue developed by Dr. Janice Travell, who's a medical doctor, and she wrote a really thick book on this technique. And I've been able to use that, and I know you've said that over time that there's been a lot of evolution and progress in going beyond Dr. Travell's work, and I can appreciate that. But I've seen some really good results with using the active release,
Right.
but using Dr. Travell's work.
Trigger point therapy you're talking about. Yeah, trigger point therapy.
And so, that's using pressure points.
Mm-hmm.
And the thing about it, again, it goes back to, I think, what I talked about earlier, that many people will get relief from that. Maybe 80% of the population will get relief, instant relief sometimes. People had conditions for a long time, and it'll get relief within minutes.
Yeah.
But again, there's that 20% of people who don't get the relief, and that's where your work comes in. And I really appreciate that so much. So I want to thank you for, your dedication to continually to learn, to grow, and to advance, and to, continue to use techniques that are, again, developed over time and more advanced than Dr. Travell's work as well.
I think to tie that in to what you're just saying there, Dr. J, is with a basic trigger point, which people will feel, a spasmed up piece of tissue, and typically they would just push down on it and push harder and push more until it kind of went away, right? That's what we're talking about. And I think where the evolution happened was we're thinking more in terms of exact nature of what tissues involved, right? Instead of just saying, here's this piece of muscle that's tight, which most people, as an example, will use is like the little knot that you'll get on your upper back. All right. Everybody, you go up to somebody, you're going to feel a big knot right there. That's something that traditionally somebody will go into and just want to push down on that thing, push harder, wait till it goes away. And a lot of times it'll work. The difference is when you have a better understanding of the layers of what's going on. Really, where that quote knot is an intersection of three muscles right there. That's usually an intersection of the trapezius, the upper trapezius, which is layer one, a muscle that goes to the neck called the levator scapulae, and a rotator cuff muscle called the supraspinatus. And where they intersect is where that kind of gets chronically scarred up. And so to take it a step further into the evolution of it is, for that same patient that has that knot, instead of us just focusing on pushing that out, it's instead thinking about why do they have that? And that gets us into most likely the person has a forward posture, right? They're tight in the front, they're pulling them forward, their neck goes forward, they're sitting in a desk all day. That's going to be somebody that no matter how often you rub out that knot on the back, it's never going to go away until you fix the why. And the why in that situation is going to be doing some work to the front of the structure to loosen up the chest, to allow them to come back and strengthen the upper back. That will then take them out of that. It's like I use an analogy with patients where if you're in a boat, there's a hole in the boat. The water in the boat is what you feel. That's the symptom of why you came in to see me. I have this knot up here, it hurts. Our job as physicians and practitioners is to find out what is the hole in the boat. Why do you have that tightness in your upper back? Well, it's because of something called upper cross syndrome. It's a postural syndrome, right? So those are examples of it, but how we would treat it differently would be in our technique, getting the exact level of what's involved by depth of our hand. So example, using our thumb, feel the tissue, push down to where it's got a restriction, or you feel a motion that's kind of adhered to its surrounding structure, right? We'll go right to that exact thing. And then what the basic system of active release techniques is shorten the particular muscle that you're on, apply attention to it longitudinally, and then lengthen that particular tissue to apply attention to it. And what we're trying to get accomplished there is to increase the circulation. And why that's important is guess what's carried in the blood? Oxygen, right? So with any of these techniques that we may be doing, at the end of the game, we're trying to bring oxygen to it because we want to break up that fibrogen type stuff that's been going on, right? So any of these techniques we've talked about, whether it be active release techniques, any kind of muscle work going on, cupping, tool work, anything. The end result is, can we get circulation, can we get flow and restore that to happening? So
Okay. So let's talk a minute about just a specific technique that again, because our average individual listening to this podcast is not going to be understanding how to do these things because they don't understand
sure.
the proximity of the muscles
Yeah.
and the origin, the insertion, and all that.
Mhm.
If let's say you're doing something in the shoulder or something maybe in the low back, talk about okay, you're pushing on a point in the muscle, or you're pushing up or down or sideways or whatever to get some motion, or but you're also moving that muscle while you're doing that technique. Talk about just a
Sure.
generalized, so give a person a visual, there's a demonstration so they can see it in their mind what you'd be doing.
So what we're trying to really do is we're trying to get a relative motion, right? Meaning we're trying to move a tissue in relation to its surrounding tissue. Okay, is what that means. So let's use an example of if I were to use my forearm, and let's just say that we had a piece in my forearm that was tight. Okay, it didn't move properly, and I wanted to actually help to try to make that move. Right, it's kind of that's the question you're getting at. Is that right?
Right, exactly.
Okay, so what we would try to do there is, and I'll use this so we could probably see it better. Maybe
Yeah, no,
is
it's good. It's good.
see it good. Okay, so if I have a little piece of tissue here that is not moving properly, it hurts. Okay, what I would be trying to do is use my thumb in this case to put it on the tissue, sink in my depth. So what I mean by that is I'm not going to come like this, which a lot of people do with like trigger point therapy, and you're going to hurt your thumb. It's going to be really painful to the patient. I'm going to try to lay my hand flat. So as I just set it onto the tissue, and you can see that I have full surface contact back here at the pad of my thumb. That's going to make it so that it's comfortable for the patient. And then I can just use my hand and get my depth by pushing in first. I'm not even doing anything with tension. I'm not moving anything. I'm just going to sink into the tissue to get my depth to where I feel I want to be. Then I'm going to draw some tension along the muscle. So in this case, I'm going towards my elbow. So my thumb is in there. I'm going to put tension towards the elbow in this case. My hand, which will impact these little muscles here in the forearm, this is going to shorten it up. So I shorten the muscle, I put tension into it, and then I'll lengthen the muscle while I hold that tension. So I'm not continuing to push harder. I'm not continuing to compress more to the tissue, right? So the objective is not, what some people do too, is I think when they want to add more tension, I think the main concept here is when you want to add more tension, that does not mean more depth. Okay. Most people, what I try to do when I'm teaching this too, is I'll talk to somebody about if I have a thickness and I want to get down to here where the problem is, I don't want to just go in and crush through everything and then just try to do my tension. That's not going to accomplish what you're looking for. I need to have the ability in my hands to get to the proper depth of where I want to go, and then blow tension longitudinally along the tissue, not compressive, but along it. When we do that, I'm now going to just lengthen the tissue underneath it, and that's why you could say yourself, and whoever else had treatment, it shouldn't hurt. It shouldn't hurt because it's not compressive. You're literally trying to hold that tissue. If you could picture a tissue that should be sliding and moving past its neighbor. And when you have a situation where they're tied up and they're not moving, that's where we start to get problem. And that's what we kind of alluded to. We got to this a while back where we talked about the cumulative strain cycle, right? And in that cycle, if we have a tissue that's not moving properly, it's going to ultimately lead to inflammation. Inflammation is going to lead to scarring. Scarring is going to lead to more tightness in the muscle. And it's a self-perpetuating cycle that continues to go. And that's why in the sports world it's been effective. That's why in the music world, you say, well, how would a musician benefit from this kind of technique? Well, they're sitting there all day long playing their instrument, and they're in a position of overuse, right? So that damages that tissue and ultimately can lead to tinglies and burnings and nerve stuff. Well, what they're frustrated with, and I'm sure you would be too, as a musician, is I just want to play, just like you want to get back to doing what you want to do. I think at the end of the day, that's the most important thing the patient cares about is, can I get back to doing what I love doing? And
Yeah.
if we can do that, yeah.
Now, could
Yeah,
you
go ahead.
talk about, Doc, could you talk about, I know you really have been a passion for treating athletes. I know you treat musicians and all that. And that's
Yeah.
wonderful. And that's really good that you can help those people. But I wanted to, before we close, because we're getting close to the time of ending this, I wanted to just talk, maybe if you could just give a brief example without giving names of maybe
Yeah.
a professional football player that you treated that had a specific injury that wasn't getting any better until they came to you.
Yeah. I mean, like I said, it's been 20 plus years of treating professional football players, especially. So I have a pretty big library of that. Um, Golly, to think of a certain thing. In reality, I'm dealing with so many areas of their body too, that the general public wouldn't realize, like ankle stuff, knee stuff, groin injuries, shoulder injuries, elbow. Um, Let me see if I can think of something here from an athlete. Hmm.
Just some dramatic case that wasn't able to be helped until they came to you and you did one of these techniques and you were able to help them significantly in a relatively short period of time, even after they've had this chronically.
It happens a lot. I'm trying to think of a specific case off the top of my head. I can give you generalities and just and talk about
Yeah,
things like,
that's
for
fine.
instance, let's think of a let's see. Let's think of somebody that uh,
Well,
okay.
while you're trying to think of something,
Yeah.
let me just share. I use this myofascial release technique, and I've had some traumatic cases where people had been going to chiropractors for months and sometimes even years. And I had this case come in one time of a woman. She was in her mid-50s, and she had actually been walking with a cane for around 6 months.
Yeah.
Walking with a cane with low back pain for 6 months.
Yeah.
And she came in one day, and I treated her with chiropractic adjustment, and I did the myofascial release technique. And she walked out without the cane. So
It's funny you say that, Dr. J, because here's a story I'll share with you that is not an athlete, but I'll come back to that. This was a story that is just, I thought was remarkable, where I had treated a family. So it would have been this particular patient I'm going to talk about, his daughter, who was an adult, and her husband and everybody. And she said to me one time, "Can you help out my dad?" He was a elderly gentleman who was a veteran, and he had a groin injury, right? So she said, "Could I bring dad in to see you?" So I said, "Sure." So she brings her dad in, and I can't make this up if I tried. He literally came in with a walker. He just been to the VA, and they diagnosed him. He's gonna be laid up forever. He's coming in to see me with a walker, for God's sakes. I said, "Let me take a look at you, see what's going on. Where do you feel it? What's going on? Blah blah blah." And I found out pretty soon. It looked like it was not going to be that big of a deal. It was a groin injury, right? So as I started to feel the guy, he laid on his back, and I was palpating the area of his leg and the thigh, and I just started kind of working the tissue a little bit, doing some protocol, and you can just see his demeanor changing. Like, what? He got off the table, and he started to move. And literally, we always laugh about this, because when I still see the daughter, because it's like, if people saw this live, they say there's no way this is happening, right? It was probably one of the most dramatic things. From our regards, I think it was just a misdiagnosis originally, but it was something where I literally just treated the guy's tissue, and he was happier than can be, because he walked out of here with no cane. And I think I only really needed to treat him like a couple times. Like, it was like 2 treatments. So that was a kind of one of those dramatic stories. That's not the norm. That was just something where it was in an area that I specialized in and was able to solve it pretty quickly. When you talk about the athlete world, I'll share an example with you that I think happens a lot. Could be any athlete, it doesn't have to be football. very commonly somebody will come in with a common diagnosis of shin pain. So they think they just have shin splints, right? So something that's often misunderstood there, or not looked at properly, is the why. I am not going to deny the fact that their shin hurts. All right. That's obviously why they're coming in. But what happens a lot of times when you ask, how can we fix these things a little quicker, is I'm going to try to look at the root of why does the shin hurt? And that goes back to us looking at the biomechanics of the person, how they move. Very often in that person, their hip extension pattern is going to be off, where hamstrings probably become more dominant. Hamstring becomes tighter. When they run or they walk or do whatever, they're going to shorten their gait. Their stride's going to be shorter. When their stride is shorter, that's going to put more load into the calf and also the quad. So they may present into me with knee pain from the tight thigh, or shin pain, heel pain, stuff like that, right? So what most people do is they just treat that area. They may want to do ultrasound, stretch it out, tape it, do whatever. And I think where we can get a little quicker results is when not only treating the tissue, yes, we need to treat that, but getting up into the pelvic, getting into the core, trying to restore that hip motion, using chiropractic. So looking at why and fixing that then cleans off the table to where they actually presented with the symptom. That happens more often than not, and very, very commonly is people chase symptoms instead of root.
Yeah, that's a good point. And I'd like to add another thing to that, another dimension to that. And oftentimes shin splints are caused, as many other soft tissue problems are caused from nutritional deficiencies like calcium and magnesium and other minerals. And that is oftentimes the underlying root cause as well.
Yeah.
Well, Dr. Zach, this has been really enlightening, and you've really shared a lot. Is there anything you'd like to share in closing?
Not really. I think for the consumers out there and anybody that's struggling with pain, I think to do yourself a good service is always exhaust all conservative methods first. There's a lot of good people out there that could help you, whether it be through nutritional, like Dr. J tries to focus into functional medicine, whether it be somebody like myself that specializes in soft tissue injuries or nerve entrapments. Don't give up on it. Try to get counsel with somebody that may specialize in that area if you become frustrated, because I know living with pain can stink, but I think you could also find somebody out there that might be able to help you get out of that to restore back to what you enjoy doing. That's what I would kind of say with that.
Thank you. I appreciate that. And so how can people get in touch with you? You're out in Westlake, Ohio.
Right.
And you have an office out there, and so they can get in touch with you if they need your help, right?
Yeah. So I'm out in Westlake, Ohio. I'm right by Crocker Park, which most people know of. You can find me on my website, which is ZachPerformanceHealth.com, which is just ZAK, ZachPerformanceHealth.com. Or my phone number is 440-892-2226. Either way, if you have a problem you're struggling with from overuse, active injury trauma, or postural syndrome, nerve entrapment, I'd love to help you out. If I could help you, I will. If I can't, I'll get you somebody that can.
Oh, Dr. Zach, this has been really wonderful. Thank you for taking the time out of your busy day to share this with us. Okay, you take care.
Thanks for having me.
We'll be talking to you again, okay?
Thank you. Thank you. Bye-bye.